Dear all, Namaste. Today I shall be discussing about cortical mastoidectomy. Cortical mastoidectomy is defined as complete exenteration of all the accessible air cells and converting them into a single cavity. Here we try our best to remove all the accessible air cells. We don't remove the inaccessible air cells like peritubal, perilabyrinthine, petrous air cells like that. In this surgery, the posterior canal wall and middle ear structures are kept intact. Therefore, this is called canal wall up technique because we don't remove the posterior superior bony canal wall. So canal wall is up or intact. What are the synonyms? In the exam, you may be asked about the synonyms of cortical mastoidectomy. They are Schwartz operation because Schwartz described this surgery. Simple mastoidectomy because this is simple surgery to exenterate the air cells. Or complete mastoidectomy, we try to remove all the accessible mastoid cells of the system. What are the indications of cortical mastoid surgery? What are the indications of cortical mastoid surgery? They are incompletely resolved ASOM with reservoir sign. Reservoir sign means immediate filling of the external canal after mopping. That means there is some reservoir in the mastoid, so that has to be cleaned by cortical mastoid surgery. Second is chronic otitis media tuber pneumatic type not responding to conservative medical treatment. If we give medicines for 7 to 10 days or maximum for 2 weeks, and if that does not resolve, the patient may have acute coalescent mastoiditis, and we should do surgery to remove the disease process. Acute coalescent mastoiditis, when there is coalescent mastoiditis, again we have to perform surgery. Maxed mastoiditis, maxed means incompletely treated ASM or CSM leading to mastoid inflammation, and that is masked because of incomplete treatment. Once we stop giving medicines, again there may be inflammation, so we have to do surgery for maxed mastoiditis also. As an approach to endolymphatic sac surgery, facial nerve decompression, CP angle tumors, that is Translabyrinthine approach, and cochlear implant surgery, we have to perform first cortical mastoid surgery, then we have to perform the other surgeries. One of the important notes to be made here is CSOM TT disease is not the indication for cortical mastoid surgery. Many of your friends in the exam, they tell that cortical mastoid surgery is performed even in CSOM TT. That is wrong. What are the steps of surgery? First, we prepare the patient. Maybe the surgery can be performed on local or general anesthesia. GA is preferred to local anesthesia. We make Wild's post-auricular incision. Then dissection of soft tissues and preparation of the graft is made. One of the advantages of temporalis fascia as a graft is that we can take the graft by same incision site by Wild's post-auricular incision. The periosteum is elevated and McEwen's triangle is identified. I think you know, McEwen's triangle is the landmark for mastoid surgery, that is surgical landmark. Then we expose the mastoid antrum, which lies around 1.5 centimeters from the McEwen's triangle in adults. Once we identify the mastoid antrum, we exenterate all the accessible air cells of the mastoid cell system. A note to be made here is, what is mastoid antrum? Why do you first access the mastoid antrum? Because mastoid antrum is the largest and most consistent air cell of the mastoid air cell system. Therefore, we first recognize the mastoid antrum, then we go towards the other air cell systems. After complete removal of the disease, we keep the graft on the tympanic membrane and we place a drain on the mastoid cavity from the post-auricular region because there may be collection of blood, and just we pack the cavity with the gel foam also. Now the wound is closed and mastoid dressing is performed. One of the important questions in Viva is, why is mastoid dressing applied? Why is this called as mastoid bandage? The answer is given somewhere else. Please refer to my video, what is the importance of mastoid dressing after mastoid surgery. This is the post-auricular incision, which is made around 5 mm away from the post-auricular sulcus. Minimum 5 mm away, okay, in the post-auricular sulcus from the upper attachment of pinna to the mastoid tip. This is the incision which has been deepened, and this is the subcutaneous tissues and the connective tissues. Here you can see the muscle. Then this is the incision made in the periosteum. This is the periosteum. Incision is made here. The periosteum is separated, and we identify the Macuan's triangle. This is the Macuan's triangle. Then we dissect here to find out the mastoidentrum, which lies around 1.5 centimeters deeper in adults. This is the mastoidentrum, which has been identified, and this is the exenterated ear cells of the mastoid ear cell system. This is the posterior bony canal wall, which is kept intact, and this is the external auditory canal. So this is canal wall of technique. What are the boundaries of the cortical mastoid surgery? They are dural or tegment plate superiorly, dural plate, posteriorly the sinus plate, inferiorly is the digastric ridge, and anterior boundary is the posterior bony canal wall, and the deep boundary or the floor is the lateral semicircular canal. This is very important. Okay, this is the floor, superior wall, posterior wall, anterior wall, and the inferior wall. This is a picture showing the different limits of cortical mastoid surgery, as already discussed. The superior wall is the dural plate, inferior boundary is the digastric ridge, anterior boundary is the posterior wall of the external auditory canal, posteriorly is the sigmoid sinus plate, and medial is the dome of lateral semicircular canal, which is very important. So this is the boundary of the cortical mastoid surgery. We should be able to look the incus, and this is the facial nerve. You can see the facial nerve here. Thank you very much. If you like this video, please subscribe my channel, Dr. Krishna Koirala, for more videos like this. Thank you.